This is Kathy Knipfer, instructor for Nursing 2203, recording the pediatric lecture for Chapter 49, Neuromuscular or Muscular Dysfunction. Cerebral palsy, or CP, also known as cerebral palsy, is a group of permanent disorders of the development of movement and postures, causing activity limitations that are attributed to non-progressive disturbances that occurred in the developing fetal or infant brain. It also may involve disturbances of perception, communication, cognition, and behavior, along with secondary musculoskeletal problems and epilepsy. Cerebral palsy is characterized by abnormal muscle tone and coordination. The incidence is 2.4 to 3.6 per 1,000 live births. It is the most common permanent physical disability in childhood. 15 to 60% of affected children also have epilepsy. Cerebral palsy is known to be caused by prenatal brain abnormalities, such as growth abnormalities of the brain, vascular occlusion, laminar degeneration, effects of low birth weight, anoxia, and hypoxic infarction or hemorrhage. Types of movement disorders in cerebral palsy include spastic, dyskinetic, ataxic, and mixed. Refer to page 1572 and box 49-1. Diagnostic evaluation of cerebral palsy. Infants at risk can be identified through careful assessment during early infancy. The condition can also be diagnosed through a neurologic examination and history. This is the primary means of diagnosis. Also, neuroimaging of the child with a suspected brain abnormality, as well as metabolic and genetic testing. Diagnosis is usually confirmed after age 2. Motor tone abnormalities prior to that time may indicate other neuromuscular illness. The practitioner also may look at persistence of primitive reflexes that normally would disappear. Clinical manifestations of cerebral palsy include delayed gross motor development, abnormal motor performance, alterations in muscle tone, abnormal postures, reflex abnormalities, and other associated disabilities. See box 49-1 as well as 49-2 and 3. These are the classification of CP, clinical manifestations of CP, and the early warning signs. These are on pages 1572 through 1574. The goals of therapy for cerebral palsy are to establish locomotion, communication, and self-help skills, to achieve optimal appearance and integration of motor functions, to correct associated defects as effectively as possible, to provide educational opportunities adapted to the child's capabilities, and to promote socialization experiences. For therapeutic management of cerebral palsy, they may wear an ankle-foot brace. They also may undergo orthopedic surgery to correct spastic deformities. These patients may receive pharmacologic agents to treat pain related to spasms and seizures. They might also receive botulinum toxin A injections. Botulinum toxin A injections, or Botox, is used to reduce spasticity in the targeted muscles. Dental hygiene is very important with these patients. Dental care is especially important for children being given phenytoin since they often develop gum hyperplasia. Physical and occupational therapies are also important. Here's an example of an assistive device used for a patient with cerebral palsy. This picture shows a tricycle that has been adapted for the patient with cerebral palsy. The prognosis of cerebral palsy depends on the type and severity of the condition. With moderate impairment, 85% of patients can achieve ambulation. Cognitive impairment occurs in 30 to 50% of these patients. Growth is affected and survival depends on comorbid conditions. Care management of the patient with cerebral palsy involves assisting the family in devising and modifying equipment and activities. It might involve medication administration, teaching safety precautions, encouraging recreational activities, setting up physical and speech and occupational therapies, and also providing support for the family. Neural tube defects are the largest group of congenital anomalies. Definitions are in box 49-4 on page 1579. Normally, the spinal cord and cauda are encased in a protective sheath of bone and meninges. Failure of neural tube closure produces defects of varying degrees. The incidence is 0.3 per 1,000 births. There has been a decrease from previous due to mandatory food fortification with folic acid. These occur more often in white and Hispanic children. Types of neural tube defects. Anencephaly is where both cerebral hemispheres are absent. It is incompatible with life. Myelodysplasia is a broad definition of any malformation of the spinal canal and cord. Spina bifida occulta is not externally visible, while spina bifida cystica is externally visible. A meningocele encases the meninges and spinal fluid, but there are no neural elements. With the myelomeningocele, it encases the meninges, spinal fluid, as well as nerves. Here are diagrams of the neural tube defects. You can see the nerves on the myelomeningocele. You can see them in the sac. A represents a myelomeningocele with an intact sac, while B shows a ruptured sac. Pathophysiology of the myelomeningocele. The neural tube fails to close during the embryo's early development. This is at approximately 3 to 4 weeks after conception. There are multifactorial causes. It may be genetic mutations related to the folate pathways. Additional factors may include maternal obesity, maternal diabetes mellitus, low vitamin B12 level, maternal hyperthermia, and medications. Spina bifida or myelomeningocele can be detected prenatally. There would be an elevated alpha-fetoprotein level in the amniotic fluid. The best time to test the maternal concentration before it decreases is at 16 to 18 weeks of gestation. It could also be detected through uterine ultrasonography or chorionic villus sampling. This sampling would not be done before 10 weeks of gestation. Therapeutic management of myelomeningocele would include postnatal care involving infection prevention, surgical closure, neuroassessment to allow early treatment. Orthopedic considerations include devices to assist with ambulation. Also, management of genitourinary function. This could be through medications, clean intermittent catheterization, or ostomies. And you have to be careful about the latex allergy. Children with spina bifida are at high risk for developing latex allergy because of the repeated exposure to latex products during surgery and during procedures. Some degree of fecal continence can be achieved in most children with myelomeningocele with diet modification, regular toilet habits, and prevention of constipation and impaction. Management might involve surgery and an ostomy. The prognosis depends on the level of the deficit. Prevention of neural tube defects. Women of childbearing age should receive supplementation of folic acid with a dosage of 0.4 milligrams per day. If there's a history of neural tube defects, the dosage would be increased to 4 milligrams per day. In 1998, the U.S. Food and Drug Administration required that cereal grains be fortified with folic acid. Supplementation should begin 1 month before a planned pregnancy. This prevents 50 to 70% of all neural tube defects. Spinal muscular atrophy type 1, also called the Wernicke-Hoffmann disease. It's an autosomal recessive trait. It's the most common paralytic form of floppy infant syndrome, also called congenital hypotonia. It involves progressive weakness and wasting of skeletal muscle. There's a variable age at onset, usually it's before 2 years. Death may occur due to respiratory failure or infection by age 2. The infant lies in a frog position, has a weak cry, cough, and generalized weakness. Active movement is usually limited to fingers and toes, and they have normal sensation and intellect. Therapeutic management of spinal muscular atrophy. It is diagnosed by genetic analysis, electromyography, and muscle biopsy. The treatment is symptomatic. It is important to prevent infection and provide vigorous treatment for an infection. Treatment of orthopedic problems, especially scoliosis, may be required. Prognosis varies with the age at onset. The later the onset, the better the prognosis. Refer to box 49-7 on page 1586 for the clinical manifestations. Spinal muscle atrophy type 3, Kugelberg-Wieslander disease. The onset is usually before 1 year of age to adulthood. The symptoms are similar to those of spinal muscular atrophy type 1. There's muscle weakness and muscular atrophy. The ability to ambulate is lost by adolescence. The life expectancy may be normal. Duchenne muscular dystrophy is also called pseudohypertrophic muscular dystrophy. It is the most severe and most common of the muscular dystrophies in childhood. It has an X-linked inheritance pattern. 1/3 of the cases result from fresh mutations. The incidence is 1 per 3,600 male births. Evidence of muscle weakness usually appears between ages 3 and 7. There is a loss of independent ambulation by ages 9 to 11. It is associated with mild to moderate cognitive impairment. It involves progressive muscle weakness, wasting, and contractures. You would see hypertrophic calf muscles in most patients. You would see progressive generalized weakness in adolescents. Death may occur from respiratory or cardiac failure. Diagnostic evaluation of Duchenne muscular dystrophy. Prenatal diagnosis may be possible as early as 12 weeks of gestation. The diagnosis is established primarily by PCR for the dystrophic chain mutation. There's a high serum creatine kinase, or CK, in the first 2 years of life. There's a positive family history, and the patient displays the usual characteristics of the disease. It can be confirmed by electromyography and muscle biopsy. Clinical manifestations of Duchenne muscular dystrophy are waddling gait, frequent falls, Gower sign, which is the characteristic way of rising from sitting or squatting on the floor, lordosis, enlarged muscles, especially in the thighs and upper arms, profound muscular atrophy in the later stages, mild to moderate mental impairment, and obesity is a common complication. See box 49-9 on page 1588. Therapeutic management of Duchenne muscular dystrophy. There is no effective treatment, but the primary goal is to maintain function in the unaffected muscles as long as possible, and to keep the child as active as possible. Therapy would include things like range of motion exercises, bracing, performance of activities of daily living, surgical release of contractures as needed, and also genetic counseling for the family. Care management of Duchenne muscular dystrophy involves a multidisciplinary team approach. This helps the child and family cope with the chronic, progressive, and debilitating nature of the disease. The program should be designed to foster independence and activity as long as possible. The child should be taught self-help skills. The nurse would provide appropriate health care assistance as the child's needs intensify, such as home health, skilled nursing facility, or respite care for the family. Let's move on to acquired neuromuscular disorders. Guillain-Barre syndrome, or GBS, is also called infectious polyneuritis. It's an acute demyelinating polyneuropathy with progressive paralysis. Children are affected less often than adults. Occurrence in children is most often between the ages of 4 and 10 years. It's an immune-mediated disease. It's often associated with a viral or bacterial infection or administration of vaccines, and it usually occurs within 10 days of a primary infection. It starts with inflammation and edema in the spinal and cranial nerves. This progresses to impaired nerve conduction and then partial or complete paralysis of the involved muscles. Diagnostic evaluation of GBS or Guillain-Barre. It's based on the paralytic manifestation, electromyographic findings, or both. The cerebrospinal fluid may have increased protein concentration, and other lab results may be within normal limits. There's symmetric paralysis, and that's part of the differential diagnosis. With GBS, initially, there is muscle tenderness, paresthesia, and muscle weakness. Paralysis rapidly ascends from the lower extremities and may involve the trunk, arms, and face. There is flaccid paralysis and loss of reflexes. There is also intercostal and phrenic nerve involvement, which results in breathlessness when talking and shallow, irregular respirations. In many patients, urinary incontinence or retention and constipation occur. There are depressed or absent tendon reflexes. Therapeutic management of GBS is symptomatic and supportive. IV immune globulin is the primary treatment if it's started within 2 weeks of the onset. These patients may require respiratory support. Medications to prevent complications include low molecular weight heparin to prevent DVT and also laxatives or stool softeners. They also might be on steroids and the IV immune globulin and plasmapheresis. They may receive pain medications such as acetaminophen. Phases of GBS include the acute phase, which lasts up to 4 weeks. Then there's a plateau where there's no further deterioration for days or weeks. And then recovery, where the patient improves for weeks or months depending on the deficits. Most patients who have GBS have a complete recovery. Better outcomes are associated with younger ages. In most patients, muscle function begins to return 2 days to 2 weeks after the onset of symptoms. The period to complete recovery is usually prolonged. Most deaths are caused by respiratory failure. Recovery of muscle strength occurs last in the lower extremities. Care management of GBS includes supportive care, observation for early signs of respiratory distress and difficulty swallowing, temporary urinary catheterization, prevention of complications, pain management, physical therapy, and of course support for the child and family. Tetanus is also called lockjaw. It's an acute, preventable, often fatal disease. It's caused by the exotoxin of Clostridium tetani. It's characterized by muscle rigidity involving the masseter and neck muscles. There are four necessary conditions for the development of tetanus: the presence of tetanus spores or vegetative forms of the bacillus, injury to tissues, wound conditions that encourage multiplication of the organism, and susceptibility of the host. With tetanus, the spores are found in the soil, dust, and gastrointestinal tract of humans and animals. The bacteria enters the body through the wound, especially punctures or crush wounds or burns. Bacteria may also enter through a scratch, a bee sting, a thorn, or a needle prick. Risk for exposure is greater during outdoor activities. The incubation is 3 to 8 days. It may be longer with the neonates. It may even be months. Pathophysiology of tetanus. Potent exotoxins spread from wounds to central nervous systems by way of neurons or the bloodstream. The toxin becomes fixed on the nerve cells of the brainstem and spinal cord. It produces muscle stiffness. It starts with progressive stiffness and tenderness of the neck and jaw muscles and spreads to all voluntary muscles. Survival beyond 4 days usually indicates recovery, but complete recovery takes weeks. Clinical manifestations of tetanus initially include progressive stiffness and tenderness of the neck and jaw muscles. The patient may have difficulty opening the mouth and may have facial muscle spasm. It becomes progressive with opisthotonus, severe back arching, difficulty swallowing, laryngospasm, and tetany of the respiratory muscles. There may be rigidity of the abdominal and limb muscles. The respiratory system is affected with accumulated secretions, atelectasis, pneumonia, and respiratory arrest. The patient is anxious but alert, and mentation is unaffected. There's a rapid heart rate, diaphoresis, and mild fever or no fever. See Box 49-11 for a review of the progressive nature on tetanus. This is on page 1592. Therapeutic management of tetanus. This disease is prevented by tetanus toxoid or tetanus antitoxin after exposure. If the patient is inadequately immunized and has a wound that's contaminated with dirt or feces, soil, or saliva, examples would be puncture wounds, avulsions, crushing injuries, burns, and frostbite. These patients should receive tetanus immunoglobulin IM injection and tetanus toxoid at separate sites. During the acute phase, care is supportive. The focus would be on airway and breathing, fluid and electrolytes, managing pain, adequate caloric intake, cleansing and surgical debridement of the wound, and care to prevent complications associated with immobility. The nurse might administer sedatives, muscle relaxants, control the environmental stimuli, and address the anxiety of the child and family. Botulism is food poisoning resulting from ingestion of the toxin produced by anaerobic bacillus Clostridium botulinum. This causes acute flaccid paralysis. Central nervous system symptoms appear abruptly in 12 to 36 hours after ingestion. The general signs are weakness, dizziness, headache, diplopia, speech difficulties, vomiting, and progressive life-threatening respiratory paralysis. Refer to Box 49-12 on page 1593. Sources of botulism in older children may be from improperly sterilized home canned foods. In infants, it may be from honey and light or dark corn syrup. Infant botulism is caused by ingestion of spores or vegetative cells of C. botulinum and subsequent release of toxins. The source of the botulism in infants is the honey and the light or dark corn syrup. There's a wide variation in the severity of the disease. It may go from mild constipation to respiratory failure. The nurse might see generalized weakness, decreased spontaneous movements, diminished or absent deep tendon reflexes, cranial nerve deficits such as loss of head control, difficulty feeding, weak cry, reduced gag reflex, and it may mimic other disorders. Diagnosis is based on the history, physical examination, and laboratory detection of the organism in the stool or the blood. Treatment of infant botulism involves administration of intravenous botulism immune globulin, or big IV, even if not confirmed through the laboratory. The nurse would provide supportive measures, such as respiratory support. This would be crucial. They may be on a ventilator. Nutritional support would be important because they're unable to feed. And then they may need stool softeners to preserve bowel function. For older children, treatment would be IV administration of botulism antitoxin. It's not the same as the big IV or BIG-IV. Spinal cord injuries generally are the result of trauma related to incidents like motor vehicle crashes, sports injuries, or birth trauma. They are classified as complete or incomplete. Incomplete lesions include, as you may recall from med-surg, central cord syndrome, anterior cord syndrome, posterior cord syndrome, Brown-Séquard syndrome, and spinal cord concussion. And you can refer to the definitions of these on page 1595 and box 49-13. Therapeutic management of spinal cord injuries begins at the scene of the injury with proper immobilization of the cervical, thoracic, and lumbar spine. Stabilization is important, along with transport to the pediatric trauma center environment. One treatment is the functional electrical stimulation, FES. An electrical stimulator is implanted with leads tunneled to the paralyzed muscles, and this allows function. This may require a tendon transfer. There may be other surgical intervention, orthoses, or ambulation aids. Treatment requires a multidisciplinary team. Nursing care for a spinal cord injury is focused on the airway. The nurse should assess neurologic status and establish a baseline. It is important to detect increased intracranial pressure early. The nurse would assess hemodynamic status, such as for neurogenic shock, assess renal, bladder, and bowel function, provide skin care, and assess temperature regulation. The nurse would observe for complications of immobility and observe for autonomic dysreflexia to prevent shock and encephalopathy. The symptoms would be a drastic increase in blood pressure, headache, bradycardia, diaphoresis, dysrhythmias, flushing, piloerection, blurred vision, nasal congestion, anxiety, and spots on the visual field.